Good afternoon. It's a pleasure to be here. I'm really excited to talk to you a little bit about communicating inherited cancer risk, uncertainty, and decision making. Before I get started, though, just want to, if I can advance my slides, there we go, to mention portions of this presentation was supported by internal grants from Texas A&M University, University of South Florida, as well as the American Cancer Society. So I would like to begin with a story. I stand close to my mother, my 8-year-old hand nestled in hers, as another cancer story is told. I glance at her breast. I wonder if the cancer is still there after the surgery that made her left breast look like my dad's. I wonder if it's a snake swallowing bits of my 38-year-old mother. I didn't know then that the snake would be in me. Not long after her surgery, my mom starts chemotherapy. I am determined to be involved. At the last treatment session, my parents let me go. I remember my mom sitting in a reclining chair with her right arm and a long tube in it. I wonder, is the snake drinking this red stuff? Then my mom starts tanning. In the wake of uncertainty, she chose to do radiation. Before her last treatment session, I lay my head on her shoulder. And the snake is there with us. Its fangs already sunk into my young chest, waiting. Now, years later, while working on my doctorate in health communication, the focus inherited cancer risk and communication, I learned I inherited a BRCA2 genetic mutation, the snake, which greatly increases my own lifetime risk of developing hereditary cancers. The snake has awoken, and it is now my turn to make decisions in the wake of uncertainty. Yet all those years ago, I always hear my mother's mantra: you make the best decision you can with the information you have at that time. And so since then, information has always been my coping mechanism. I underwent genetic testing all those years ago because I believe that knowledge is power. And with the knowledge about my genetic predisposition, I now engage in health decisions to prevent and detect any cancer in my body. It's also my belief in knowledge that has inspired me all so long ago to be a professor and a cancer researcher. And finally, it was that commitment to have public-facing materials, and I participated in the CDC's Bring Your Brave campaign, which you see here. In short, my entire life has focused and been full of intentional decisions, both personal and career-wise, in order to cope with an uncertain future. By welding my role as a professor, a researcher, and an advocate, I seek to improve patients' and families' health experiences, but also develop communication-based tools to improve health outcomes. So if you could join me on this journey for just a little while, I'd like to share with you just 3 research decisions which are infused with experiences from my own family and the patient community surrounding inherited cancer risk. So most of my research focuses on men and women with inherited cancer risks, but who have not been diagnosed with cancer. People like me. I try to understand how they manage uncertainty, make informed health decisions, and ultimately communicate genetic risk information with family members and clinicians. Genetic testing for predisposition helps identify individuals at significantly increased risk to develop cancer, and then can guide prevention and treatment, right, to reduce cancer incidence and mortality. Those with inherited mutations who have not been diagnosed with cancer, like myself, are commonly referred to as unaffected carriers, but they're also called previvors. This label was coined by the national nonprofit organization FORCE, Facing Our Risk of Cancer Empowered, an organization dedicated to aiding those affected by hereditary cancer. The term previvor was motivated by a need to not dismiss significant ongoing stress and complex decisions faced by these individuals, and thereby recognizing them as survivors of a predisposition to cancer. In other words, While we as previvors, we face a level of certainty that our risk for developing hereditary cancer is high, we also live with chronic uncertainty about our risk, not knowing for sure if we will develop cancer, and if we do, when we might develop the disease, as you can see by this quote here. But as genetic testing becomes more widely accessible and available, the previvor population will likely grow and develop. So the first study I'd like to share with you out of 3 is called ePower, and it really focuses on the previvors cancer risk management decision-making process. So extant research supports this notion that risk-related uncertainty is number 1, inherent for previvors, number 2, more intense, and number 3, experienced chronically. Uncertainty exists when we believe aspects of our situation are ambiguous, complex, or unpredictable. So for example, some of my work has identified main sources of uncertainty for previvors. Medical uncertainty includes being anxious about a future cancer diagnosis, feeling fearful during increased surveillance appointments such as breast MRIs, or waiting for diagnostic test results to come back when a hereditary cancer is suspected. There's also familial uncertainty that we deal with, and this includes distress when we're reflecting on cancer memories, such as death of a loved one, or worrying about how a hereditary cancer diagnosis could affect our current or future children. The problem arises when uncertainty is left unmanaged. Unmanaged uncertainty has detrimental effects, including poor health decision-making and potentially increased cancer diagnoses and mortality. In fact, a few studies have found that previvors may face more psychological distress than even patients diagnosed with breast cancer. A previvor's ability to cope with that distress is thus essential. So this study was framed by uncertainty management theorizing, and specifically my colleague and I utilized 3 uncertainty management constructs that you see listed here, which really inform the individual's experiences as well as their decision-making. Number 1, those sources of uncertainty. Number 2, how it is appraised or assessed. And number 3, how the uncertainty is strategically managed. And this theoretical framework also guides our overall translational goal to help women process their uncertainty and make these difficult decisions. To briefly overview, for previvors, managing their uncertainty means making specific medical decisions. Previvors specifically with BRCA 1 and 2, which this study focused on, have 3 main options other than to do nothing for managing their risk. Increased surveillance, right? Actively monitoring the body, prophylactic surgeries, removing tissue to prevent breast cancer, or removing ovaries and fallopian tubes to prevent ovarian cancer, and then chemo prevention, administering medication to delay cancer as well as reduce risk. But while these cancer risk management options are ways to manage previvors' uncertainty, little is known about how this uncertainty informs decisions or how uncertainty is impacted in those decision-making processes. So we ask the question, how does uncertainty inform women's medical decision-making process after testing positive for a BRCA1 or BRCA2 mutation? This study was primarily qualitative. We conducted telephone interviews with 46 BRCA previvors. Following IRB approval, we recruited participants through the national organization I mentioned earlier, FORCE, as well as then snowball sampling. And we conducted a thematic analysis using the constant comparison method to analyze the interview data. And we also conducted member checks at the end to see if the results resonated with our participants. Just briefly, so overall, we identified 2 main decision-making pathways of previvors, which manifested differently depending on the decision. And what I mean by decision is the uncertainty management choice the women made based on their perception of threat and then the available information to them. Now, I want to point out that chemo prevention was not identified in this sample. So here's the first pathway, was risk-reducing surgery. So most participants in our sample chose surgery, specifically a prophylactic bilateral mastectomy or a bilateral salpingo-oophorectomy. And as depicted in this pathway, previvors who first appraised or assessed their uncertainty as a danger chose surgery, as well as their risk-reducing medical decision, and then thus that resulted in health-enhancing outcomes. So appraising their uncertainty as a danger meant that they saw it as a gamble or a risk, and thus that heightened their emotional distress or extreme distress. So for example, one participant said, "I don't even gamble in Vegas. Why on earth would I gamble on this?" Number two factors informed previvors' risk-reducing surgeries decisions, being done with having children and feeling like a ticking time bomb. One previvor said, "I just feel like, why am I going to wait to get cancer? I valued my life more than my body parts." And then finally, previvors who chose surgery reported these interconnected health-enhancing outcomes. In other words, previvors described how their decisions to undergo these risk-reducing surgeries ended up reducing their risk-related uncertainty and then eliminated their disease probability and enhanced their psychological well-being. One previvor summarized, "I don't have to worry about getting cancer every day now." The second pathway was increased surveillance. So these previvors appraised their uncertainty as an opportunity, and so instead chose increased surveillance as their decision, which resulted in both health-enhancing and health-inhibiting outcomes. Previvors noted two specific characteristics of this opportunity appraisal process. First, they described how it was an opportunity for personal control. One previvor said, "Having a plan to do something about it gives me some control back." And second, these previvors stressed the importance of having the ability to detect cancer early when so many of their other family members were not able to do so. Moving to the next, two factors then informed previvors' increased surveillance decisions, wanting to have children and concerns about surgical side effects. One previvor said, "My main thing is that I want to have a family." Last, these previvors who chose surveillance reported both health-enhancing and health-inhibiting outcomes tied to that uncertainty. They described how initially, when they made their increased surveillance decision, it helped them manage their risk-related uncertainty, which then promoted health and reduced their uncertainty. However, because their uncertainty was managed, not reduced, as in the case of surgery, it persisted. They encountered psychological distress associated with chronic uncertainty. This is best demonstrated by one previvor who said, "If I do nothing and wait, and then I get sick, I had all this knowledge and I wasted it." So we found this aspect of the results really interesting, that even after making a decision to engage in increased surveillance, these previvors continue to experience that risk-related uncertainty. So with that in mind, we returned to the data and extended our analysis, and we found, as depicted here, that the uncertainty appraisal process for these women was cyclical. It wasn't linear. So for these previvors, their uncertainty was no longer described as an opportunity as it was initially, but then appraised as a danger. Their danger appraisal, though, was different than those who had chosen risk-reducing surgeries. For these previvors, the danger appraisal was informed by the experience of distressful uncertainty triggers. So going to a surveillance appointment, right? And then in thinking about family planning. So after reappraising the uncertainty as a danger, these previvors described reconsidering those options. What's interesting, though, is that they didn't actually change their surveillance decision. They just constantly reconsidered those options. So this ongoing contemplation helps them manage their ongoing uncertainty and was informed by time that had passed as well as older age. One previvor demonstrates this when she said, "I don't want to push it," referring to risk-reducing surgery, "off forever. I'd like to know maybe in a year or so." And then finally, previvors' appraisal and subsequent ongoing contemplation of options was health inhibiting and embedded in that psychological chronic uncertainty, which they had to continually manage over time. These participants described false hope, which was masked as anxiety and worry, and then again, feeling like it was a gamble or a risk. One previvor exemplified this when she said, "I'm gambling that I can live my life happy enough for a few more years, or as many years as I can push it, and I pray to God that I don't get cancer." So what does all this mean? Overall, from this study, we learned that previvors experience this chronic uncertainty that's associated with their cancer risk decision-making, and that's influenced across their lifetime. Based on these experiences, I think it's important to understand two main points. The first, previvors make sense of those decision-making options by assessing the impact of that decision on their uncertainty, and then how it'll affect their psychological distress. And number two, previvors' uncertainty, their emotional distress, and ultimately their decisions are influenced by lifespan factors, which are located at the center of this model that you see here. So, such as becoming an adult, finding a partner, perhaps getting married, trying to build your family, and being pregnant without surveillance. Our next goal for this project is to get some feedback from previvors and clinicians to see how this model might be helpful in terms of decision-making processes. So let me change gears now to another project which is focused on men at risk for BRCA-related cancers. And this was in collaboration with Dr. Emily Rauscher. And what's interesting about this project is we started off focusing specifically on how male and female previvors communicated with their family members about genetic risk information. But not surprisingly, when you engage in qualitative research, what you're interested in doesn't always end up being what comes out of the data. And that was the case for this particular facet of this study. So men's experiences with their healthcare providers really arose in the data as being really important. So I'm going to share with you a little bit about that study. So men are also at risk for inherited cancer, right? However, men largely remain unaware of BRCA-related cancer risks, as well as their cancer risk management options. And research says that they undergo genetic testing at 1/10 of the rate that women do. One reason perhaps for this lack of awareness and lack of genetic testing may be due to the lack of information specific to men. And lack of information, we know from the literature, produces uncertainty, which I just discussed, and can cause distress. Finally, cancer risk management for male BRCA1 and BRCA2 carriers is challenging. There are clinical screening guidelines recommended by the National Comprehensive Cancer Network, but really little is known as if men attend such appointments, and if there are almost no studies to examine that clinician-patient interaction in the case of men's experiences. This gap is problematic because we need to understand men's experiences in order to improve their adherence to clinical guidelines, as well as assist them in making health and family decisions and ultimately improve their health outcomes. This study was framed by expectancy violation theory, or EVT. And this theory posits that when we interact with others, we react to unexpected violations of social norms, and we do that either positively or negatively. So social norms, the unwritten behavioral rules that are maintained by our society. And so when that happens, we react to these unexpected violations in positive and negative ways, and then it's our reactions to that which ultimately influences how the interaction is going to go. Given the scarcity of research on this topic and framed by this theory, we ask the simple question, what are men's experiences when they interact with their healthcare providers regarding BRCA-related cancer risks, and what were the outcomes of violations to those expectations? Again, following IRB approval, we conducted purposive sampling, as this is a difficult population to identify and enroll. Dr. Rauscher and I conducted 25 individual telephone interviews, and participants received gift cards for appreciation of their time. And we also, again, conducted member checks at the end of the study to see if the results resonated with participants. So overall, informed by our theoretical framework, our analysis revealed a three-stage process for understanding men's experiences when they're interacting with their clinicians. The stages include expectations, violations, and then outcomes, which I'll discuss each one at a time. So to begin, as you see here, men with BRCA-related cancer risks expected their clinicians to provide guidance and care for managing their hereditary cancer risks. And specifically, two properties or sub-themes emerged in this stage. So first, when men were interacting with their healthcare providers, men expected their doctors to obtain their relevant health information through patient history and medical forms. So for example, you see Kyle here, who explains that he thought by filling out his medical forms, that was the equivalent to disclosing his BRCA genetic test results to his doctor. Second, when meeting a new doctor, men reported disclosing their family's hereditary history during consultations, and in some cases, their own inherited gene mutation. In this quote here, Jeff talks about how he disclosed his BRCA status to doctors, particularly new ones, which then leads us to the next stage, violations. So the first violated expectation was men's assumptions that their doctors would be knowledgeable about BRCA and that the information shared by their healthcare providers would help them manage their risks. Now, excluding genetic counselors, men like Derek reported that their physicians were largely unaware of BRCA and its associated cancer risks for men. Now, this isn't surprising, as there is a recent systematic review which found that primary care physicians are largely unprepared to assist patients in assessing information about hereditary cancer risk. And there's survey research to suggest that only 37% of physicians were actually aware that a pathogenic variant in BRCA can be passed down by males in the family. The second violated expectation was men's expectations that their doctors would take their BRCA-related cancer risks, in their words, seriously. Instead, what they reported is that clinicians downplayed their risks. You see that with Jeff's quote here. He reported that his doctor never seemed concerned about BRCA, nor did he even mention BRCA during his clinical interactions once he had disclosed that information. So because in these experiences, clinicians were not knowledgeable, nor did they provide pertinent health information and resources, there were two main outcomes that came out for these participants. And the first is that men experienced less worry. Gabe reported, for example, that his doctor was not really fazed by his family's history of cancer, his BRCA status, and which made him conclude that really he didn't have anything to worry about. And then second, men also stated equally that they had to educate or act as advocates for themselves in clinical interactions. You see that in Ryan's quote here, as he talks about how he had to work really hard to educate his doctors about males and BRCA in order to get the care he wanted and desired. So overall, this study revealed that men's expectations when interacting with clinicians might be a barrier to their ability to manage inherited cancer risks. Participants expected their physicians to be knowledgeable, gather information, and provide clinical recommendations in order to tailor it to their specific situation. Yet when their physicians often negatively violated those expectations, this decreased the chances that the patients would adhere to risk reduction, even undergo genetic testing in some cases, and ultimately impacted how they framed their risks for themselves as well as their family. Again, this is problematic because we already know that extant research that with men are getting tested at lower numbers, and that men tend to focus more on the familial implications of hereditary cancer risk. So perhaps one important implication for this is an additional need for training for genetic practitioners, primary care physicians on collecting but also utilizing family health information. And we believe focusing on this skill might be helpful, since research indicates that some patients often don't know what is relevant in their family health history to begin with. So perhaps some fruitful areas for future research is educational resources for general practitioners and primary care physicians, updating their knowledge, and also given this is one small snapshot of this experience in a small sample, we believe additional research is needed to explore this further, maybe conducting observations of patients and clinicians' interactions, as well as learning healthcare providers' perspectives on these interactions as well, an important component. So if you can stay with me for the third study, kind of giving you an overall spectrum of different communication experiences for these types of patients. So my last study focuses on facilitating communication about fertility and inherited cancer risk between previvors and their partners. As I mentioned, and as you might have noticed, an underlining factor in previvors, male and females previvors' health journeys is this issue of family. And in the context of hereditary cancer risk, previvors have unique challenges and concerns when making family building decisions. And to be clear, I define family building as the act and process of decision making about children. So that could be timing, the number, the approach, the method, etc. As just one example, one challenge for these couples may be passing on a genetic mutation, because as carriers have up to a 50% risk of passing on their pathogenic variant to each future offspring. Now, previous research has found that in the case of inherited cancer risk and fertility decision making, that it's often difficult and it takes time. Now, it's important to acknowledge that in comparison to cancer patients, previvors don't have cancer, right? So they have the time to make these cancer risk management decisions, as I previously discussed, but that also can have impacts on their family building, such as loss of childbearing, breastfeeding, things like that. Some of my research has found when previvors are making these family building decisions that they engage in two different types of decision making. One is a logical frame of mind, and the other is an emotional decision making style. What these previvors talk about is wanting to undergo these risk reducing uncertainties in a logical time frame that's been outlined by NCCN guidelines or their healthcare providers, but they also have to keep in mind their emotional desires to be mothers and often have biological children and breastfeed. So to this end, research has found that some previvors consider postponing risk-reducing surgeries, do postpone risk-reducing surgeries in order to complete their families. Yet what complicates this decision-making further is that it's not individual, right? It's interpersonal, meaning that involves the communication between the previvor and the partner together. When communicating about family building, previvors and their partners often experience significant communication challenges. As one example, discussing the belief about passing on a pathogenic variant to possible offspring can create tension, conflict between couples, but also has implications for the broader extended family too. This is just some advice here from a recent study Dr. Rauscher and I conducted about previvors' advice for newly diagnosed previvors and things that they would encourage them to do when they're communicating with their partners. Engage in two-way dialogue across their lifespan. Seek information about assisted reproductive technologies. Recognize each other's social support needs, and acknowledge and manage emotions in these difficult decisions. So given this need, we developed the caring tool. And it's a theoretically informed, multi-stage dyadic decision support tool for couples, and it seeks to provide ongoing support to dyads and complement the evolving role of genetic providers in this genomic era. So let me tell you a little bit about the tool just briefly. It starts out by setting up the context, and we explain that couples in their situation may struggle with decision making about building their families, and thus they might have concerns such as passing on an inherited mutation to future children. It's a longitudinal, so at time point 1, to help the couple discuss and identify their initial concerns about building their families. It sets it up in the comfort of their own home at the time that is convenient for them. And the couple starts off by sitting down and listing separately 3 specific concerns on a sheet of paper or on their phone that they have about building their families. And then they rate how important these concerns are to them from 1 to 3. Next, the couple takes turns sharing those concerns with each other. And to help facilitate this conversation, we provide a variety of questions as well as advice to equally spend the same amounts of time sharing. And this conversational exercise takes about 15 minutes. Then a few months later at time point 2, the couple has another structured conversation. And once again, we set up that context saying that it's been a couple months since the initial conversation, and research has found that couples might report difficulty when having these conversations because topics might tend to come up haphazardly in the car, at the dining room table, right? And so it gives the couple the opportunity to discuss and understand each other's concerns. And this is called communicated perspective taking. And the ultimate goal is to make a family building decision at this point. So first, the couple separately lists one topic that is related to family building and genetic risk that is easy, difficult, and then creates disagreement or conflict. And again, the couple is instructed to share the topics with each other, and we provide some guidelines for having this conversation. This conversational exercise takes a little bit longer, but again, around 20 minutes. So we conducted a single arm pilot over 2 time points. At both time points, couples first completed a semi-structured discussion task using the Caring tool, and then an online post-discussion questionnaire and a dyadic interview with an interviewer. We recorded and transcribed the discussion tasks, and the dyadic interview data were analyzed. Again, this is a longitudinal study. We had 15 couples, so 30 individuals. And couples were recruited through social media and snowball sampling. Couples gave informed consent and participated in their semi-structured discussion tasks and the dyadic interviews at both time points. And then my co-authors and I utilized applied thematic analysis to code the data in MaxQDA, which is a qualitative data analysis computer software program. And partners and previvors were compensated at each time point. So overall, in this pilot, we found that the Caring tool is feasible and acceptable. Feasibility was assessed in 2 ways. Number 1, recruitment success, and number 2, intervention completion. Now, it's important to note that this study started in May of 2020. So this is why we originally started with clinical referral, and that was not successful during the height of COVID. So we quickly, since it was grant funded, moved to recruit online and quickly recruited 15 participants in 2 months. Like I said, these 15 couples participated. So time 1 was May to June of 2020, depending on when they were enrolled. And then time 2 was July to September of 2020. And it's important to note that 13 couples participated in that time point because we had 2 couples who withdrew. They had a change in fertility status, so it made them ineligible to continue the study. For the discussion task number 1, participants rank ordered their concerns quite easily. And at time point 1, only 1 participant listed 2 concerns instead of the 3 that we had asked them. For time point 2's discussion task, couples listed a topic that was easy to discuss, difficult to discuss, and caused conflict and disagreement. And at this time point, a few couples noted in the interviews that they had a difficult time coming up with the conflict or disagreement topics. On the right-hand side, acceptability was assessed in 2 ways. Number 1, through the dyadic interviews that we conducted after the discussion task, and to determine if participants liked the intervention and if they found it helpful. And then also post questionnaires to determine if participants' perceptions of their interactions with their partner, as well as those emotional responses after engaging in the pilot. Overall, couples noted the usefulness for the pilot. As just one example, couples made comments about the organized nature. So for example, one previvor said, Having the time for these structured conversations is really cool. It's different. Usually these things come up haphazardly. So when you really put the time into talking about something that's difficult, you end up being more focused, and that's really nice. Additionally, as you see in this table, post-questionnaire results at both time point 1 and time point 2 revealed that the pilot intervention was not stressful, and overall participants felt relatively high levels of intimacy and disclosure with their partner after the interaction. In terms of the pilot intervention's outcomes now, so we identified 3 main themes in the dyadic interview data, which you see listed here on the left-hand side, and then you see exemplar quotes provided in the far right column. I'm not going to go through examples, but just kind of give you an overview. So first, previvors and their partners noted that the discussion task helped them realize concordant concerns about family building and inherited cancer risks. So this is in contrast to organic conversations about this that might occur in day-to-day. In the dyadic interviews, couples talked about that the discussion tasks really helped them discuss with each other what their perspectives were about family building and why and how certain options were prioritized in terms of decision making. Second, the couples also noted that the task actually prompted them to discover or confront discordant concerns. And discovering discordant concerns sometimes resulted in highlighting relational conflict between the couple. However, discovering those discordant concerns or dissimilar wasn't always negative. So for example, some couples, they shared how learning about their partner's discordant concerns actually allowed them to take note of their partner's unique perspectives when it comes to family planning and then consider those options that their partner found important. Finally, the couples noted that the task helped them work through and agree upon next steps for having children. So in other words, the discussion tasks focus on discussing those concerns, allowed the couples to take stock of dissimilar concerns, and then jointly identify next steps in terms of family building. So in summary, to our knowledge, the Caring tool is the first developed for couples with inherited cancer risk. And we found from this study that the intervention is feasible and acceptable and provides at least a starting framework for guiding communication about family building decisions. We believe the Caring tool is novel as it includes partners of previvors as instrumental stakeholders in fertility health decision making. And additionally, by providing structured time and facilitating communication between couples, the Caring tool helps previvors and their partners reach an agreement about completing their families while considering the previvor's inherited cancer risk. The Caring tool, we hope, may aid fertility and genetic providers in clinical interactions with couples in the future. But a few next steps points. Number one, it's important to note that across all of these samples, really, the sampling strategy is likely attributed to the lack of diversity in the samples. And so it's our goal for future research, particularly next steps for this Caring study, to explore couples' experiences who are genetically, racially, ethnically, socioeconomically, and sexually diverse. And then additionally, we hope future studies with larger sample sizes will be able to assess the efficacy of the Caring tool and ultimately improve communication satisfaction and enhance communicated perspective taking. So I may have an uncertain future, previvors do, but we all do, right? But I choose to embrace this part of my identity, striving to help others while continuing to challenge myself. I choose to remember my mother's very wise words and make the best decisions I can with the information I have at that time. I want to acknowledge that all the research that I shared with you from our Cancer Communication Research Lab would not be possible without an excellent research team at the medical institutes and the organizations that I've partnered with. And I'd also like to thank the many previvors who I've worked with over the last decade who have shared experiences with me in the hopes of improving communication about inherited cancer risk. So thank you so much for your time and attention, and thank you to our online audience, and I look forward to your questions.